Hello, welcome to the lecture on CVD risk assessment and management. So let us first understand what is CVD risk prediction. It is the process of identifying individuals based on the probability that they might develop a CVD event in the next 10 years. Here, an event includes myocardial infarction or stroke, which could be both fatal or non-fatal. Why do we use the total CVD risk? CVD risk factors, when present together, not only act in an additive way but help each other, that means in a synergistic manner, to increase the total risk. For example, if high blood pressure alone raises the risk of CVD by say X degree and total cholesterol alone raises the risk by Y degree, then the total CVD risk of both these conditions existing together in an individual is not X plus Y, it's actually more than that. So that is the reason why we need to assess a total risk of the risks which are of all the total factors which are present in an individual. Then how will you get a better yield, which in the sense that which are the risk groups that you would like to assess in order to get better yield? Let us look at this example. Say in the age group of 30 to 40 years, there is one person who is in the high risk category. Another group of 40 to 50 years, there are 4 people in the high risk category, and 50 to 60 years, there are much more people. So if you see this, it is only logical to understand that the higher yield will be when you screen people above 40 years of age. Though we can do it at 30 as well, but the yield will not be as high. So we have to look at the efficiency and the cost effectiveness of the program. So therefore, let us come to the guidelines as to when you can use the CVD risk assessment. As I've explained, age over 40 years, now you can understand why we have taken over 40. Then the risk is high when people use tobacco or are overweight, or there are known cases of hypertension, etc. So these are the individuals who will need to have their CVD risk assessed. Now, how will you assess the CVD risk? I have demonstrated to you the use of the CVD risk calculator in the Pen app. So that is a simple and a direct way of getting the CVD risk. Or you can use the printed charts which are given in the R module. But remember, when you're using the charts, you will have to use a chart which is for South Asia, not Southeast Asia. South Asia charts will contain the country for India if you are doing the CVD risk in India. So WHO has brought out two kinds of charts. One is a lab-based charts and other is a non-lab-based charts. So what are these lab-based charts? Lab-based charts are actually use these parameters for calculating the risk, that is age, sex, smoking, systolic blood pressure, and the laboratory part of it is the blood glucose, which determines the diabetes, and total cholesterol. But remember that even if a person is already a known diabetic, you can use the lab-based chart, provided you have the total cholesterol values. So when you use the risk calculator or when you use the chart, you'll find out that the risk score is actually color coded. So which is green, that is low risk, yellow and green are assumed to be low risk, orange is moderate, and red and deep red will be high risk. So what does overall risk of 15% mean? It means that for every 100 people exactly like the patient, say the same age, sex, blood pressure, smoking, etc., 15 of them will have a CVD event within the next 10 years. So, after assessing the CVD risk, what will you do? Here I want you to understand that calculating the CVD risk is not simply generating a score, a number, but according to the guidelines, after you assess the CVD risk score, you also have to look at the interpretation and the follow-up action. For example, if a person is having a low risk, you definitely have to counsel him or her on diet, physical activity, smoking, and alcohol, which are the mainstay and always will be the mainstay of prevention and management of NCDs. At the same time, if the patient is has hypertensive, you have to see according to the treatment protocols and start with non-drug treatment, and follow-up of the person has to be done once in a year. Then if the person is on a risk level of 5 to 10%, again you continue in the same way, as because it is still in the low risk category, but you have to call the person for follow-up more frequently, maybe every 3 months, and then 6 to 9 months later after the targets are met. A medium risk person will need to be also counseled, but the difference is that follow-up has to be more closely. Now, once the CVD risk is high, or high risk, more than 20 or 30%, then according to the recommendations, you may actually have to consider giving a statin, because these are the people who are at very high risk. So, and follow-up has to be done very closely every 3 months. And if there is no reduction of the risk after 6 months, you have to refer for follow-up to our next level. Now, coming to the CVD risk assessment using the non-lab based charts, we have seen that whenever the information on cholesterol or blood sugar is available, you can easily use the lab based. But as we know that in many conditions, especially in the field conditions, you may not always have the information of a cholesterol. We may have some information about, we can do check the blood glucose, but then cholesterol is not often available. So in that case, how do we do? So the non-lab based charts can be used to assess the risk where there is no laboratory confirmation or no laboratory services, by using the same parameters as age, sex, the systolic blood pressure, or smoking or non-smoking status. But instead of the diabetes and cholesterol status, we have to use the BMI. So you measure the height and the weight, and it will give you the and you can use the non-lab based charts. Now, what is the advice after you assess an individual using non-lab based charts? Here, the cutoff level is lower. So if somebody is having 10% risk and above, he or she should receive an assessment using the lab-based charts, or basically you have to refer the person for some more investigations, especially for diabetes and cholesterol. And the lifestyle modification advice has to be continued as usual for all individuals above the age of 40. Now, with that background, let me just take you through different scenarios as to how the different parameters have an effect on the total lab-based score. Say, for example, here I've taken 3 countries of women, of a female of 45 years who is smoker and no diabetes, and having systolic blood pressure of 148 and cholesterol level millimoles per liter. And again, as I've explained earlier, the cholesterol level in for assessment of CVD risk always has to be in millimoles. So here you see that for the same parameters, somebody who's living in Sudan has a higher risk, almost twice the risk as those who are staying in India or Philippines. But if you change the age, see what happens. The risk also changes, it increases in all the categories. That means age is a strong predictor of, or modifying factor for risks, increases the CVD risk rather. So instead of females, if we take males with the same parameters, you see how the risk increases, which means that the CVD risk is higher in males as compared to females, given the same conditions. As you have seen, in all the conditions, follow-up is a very important component. It's not that assessing a CVD risk is a one-time activity. And in each follow-up, as we do for clinical assessment, we ask about developing of symptoms, adherence to advice, especially on the risk factors and medications, and we repeat the cardiovascular risk each time. So this will also serve as an important educational tool for the patient himself or herself to see what has been the change. If there is any change in the CVD risk, that will also can be reflected by the CVD assessment, and a person can understand where he or she stands. So, but remember that CVD risk is not needed in certain conditions. For example, if the person has already had CVD event, they already had myocardial infarction or stroke, even just TIA, okay, and patients with albuminuria and all the complications, and people with very high level of cholesterol, so that means they're already at risk, so you don't really have to assess the risk any longer. So in summary, these are the parameters for estimating the risk both on lab-based and non-lab-based, which I hope by now you are very clear on, and we have also demonstrated through the exercise. So that is all for my side.